Thank you so much. Great honor to be here. And I'm going to present the data, but what you're going to see I'm going to do is I'm going to put the slides up with all the references. So if you want to pour through the references and you want to get all into the data, that's great. I'm going to tell you the data is a lot of baloney. And the truth is, we should think more like businessmen than doctors. What do I mean? Well, I have an MBA. I make more money in business than I do in surgery, but surgery is much more fun and is much more noble way to make money. But you don't think businessmen wait for p-values or prospective randomized trials to determine what stock to pick or where the market is headed. And they use vision and they skate to where the puck is going to be or where the soccer ball is going to be as opposed to where it is. So my point to you is I can show you these studies, and I will, and really Bernie Park did a lot of this work, and I want to thank Dr. Park for doing some of this. I'll put his name up in some of the slides. And the references are there, but I want to leave time to really discuss. So I'm going to try to give some time back to have a discussion because pain and quality of life are all things that it's very hard to show. But for those in the room that do how many people in the room do robotic surgery? Okay, how many people in the room do both robotic and VATS? How many people in the room, if they had the choice to do a robotic lobe versus a VATS lobe, would pick a VATS lobe? That is shocking. One hand, and I'm going to ask you why. Tell me why. Yeah.
In my hands, it's easier and quicker to do a VATS lobe.
There you go. So he's inexperienced on the robot. Yeah. So how many robots have you done?
I only started this year.
There you go. So the only person that ever answers that question, VATS, is an inexperienced robotic person because people vote with their feet. And where has all the volume gone? Robotic. Because it's better for you. And no one talks about the surgeon. But as a previous, and here is my conflicts of interests, I have to put these up. So I was an executive VP, chief operating officer, and vice dean of NYU, New York University Langone Medical Center for 5 years. I did not resign that. I'm not doing that the last year, thank God. But the point is, people vote with their feet. They all wanted to do robotics. And I have no conflict of interest then. They made me get rid of it, so Intuitive doesn't pay me for any more talks anymore like they used to. I haven't gotten a check from Intuitive in 7 years, and it's fine. And my opinion hasn't changed. The robot's dramatically better, and we'll talk about why. So I care about the physicians I serve, both as a chair, or as a chief, or as a COO, and the physician's life are better, so much so that we do 25 gastric bypasses a day, 25 a day. I made all those surgeons switch from laparoscopic to robotic, and it cost me more money, but it was better for the surgeons. They have less ergonomic problems, less issues with their bodies. So now I want to thank Dr. Park. Dr. Park gave this talk. Recently, I was in the audience, and I said, Bernie, I got to give this talk. I'm going to steal a lot of your slides. Thank you. I'll give you all the credit. Who here knows Dr. Bernie Park at Sloan Kettering? Wonderful man, great surgeon, and really did a lot of the work here, so I'm going to use many of his slides. Now, Bernie got into the details. I'm not, but I'm going to put them all up. Here's the single most important slide I give you. And I want you to take your camera out because I get this at the end of the talk all the time. I'm like, I put it up. Please take a picture. So we're very blessed to have had over 800 visiting surgeons come watch us operate. One of my time in Alabama and New York, and they really come to see my partner, Dr. Mike Zervos, more than me. Mike does twice the volume I do and does it twice as well. So if you come to New York, you want to come on a Monday, Tuesday, Wednesday. I only operate the 2 days a week. Dr. Zervos operates 3. But we're welcome to have you. And I think we already are booked up for a year because the hospital won't let us have more than 3 visitors a day now for some stupid reason. But please take a picture of this. And then I have a YouTube channel. You know, when I was COO, they wouldn't let me post on it. They wouldn't let me sit on boards. They wouldn't let me do some investments. It was very restrictive. It's another reason I got out of it. But I'm now back posting our operations. I don't know why I couldn't do it as COO. But I think a lot of the techniques, for instance, we had a case yesterday. We got around the main pulmonary artery without taking the right upper lobe vein. And it just shows how we get proximal control robotic. We just do it all the time. For us, it's reflexive. You know, you have a difficult case, you got to get 3 or 4 cases done. You can't take more than 2 hours. You're doing a complicated sleeve, right upper lobe. Just get proximal control of the pulmonary artery. We'll post that on our YouTube video when I get back on Wednesday. But please go to the YouTube channel, put in Cerfolio surgery. I get no money, I don't get paid, but it's there to teach you robotic skills. Or come send me an email if you want to come visit, or send me a text. Okay, now the data. So look, minimally invasive is better than open. Do we need to spend time talking about that? No, so let's skip it. So what's the argument? So the argument is thoracoscopic better than robotic, and how do we get to that data? So we get to that data with hopefully prospective randomized trials. Prospective randomized trials are much better than retrospectives. But here's one that's retrospective, and the primary outcome is mortality. Again, I'm going to tell you that people vote with their feet, not patients, but surgeons. So really, we're not even going to talk about ergonomics today, but we have very good data now that the robot extends your career and extends your ability to do things. I see that Joel just came in, and Joel will tell you that it's going to be better. And yes, Joel, I got prospective randomized trials coming. It's better for your body, and we're going to actually show you really good data with that. It's going to take us a few years. And then Bernie puts the slide about length of stay. Now look, length of stay is baloney. It has nothing to do with platform. All of our patients go home on 1 day. Now, everybody, we almost mandate it. We always get those 1 or 2 super rich, arrogant people that won't leave on the first day because they have a chest tube and they don't want to go home with a tube in. But now we're doing it the best we can. So you can do a thoracotomy and send them home on postoperative day 1. It's all how you manage your tube. So we have digital chest tube drainages and everybody goes home. So this shows a shorter length of stay, but if you're a VATS argument, you get up and say that it has nothing to do with platform, and I totally agree. So Bernie, it's a good slide by Bernie, but I got to skip it because it's not right, and it says further research is needed on patient-centered outcomes. That's correct, but really what's needed at the end of the day is not just how the patient feels, but how the surgeon feels, how the surgical team feels, how the anesthesiologist feels, and the PA feels. When you're doing a uniportal VATS, do you think the person holding the camera is happy at the end of the case? Or are they happier if they're sitting on a robotic console? That's all part of it. As a COO, it's how the team feels, not just the patient and not just the coffers, how much money we make, but how happy the employee is. The fact is, the happiness of the employee outweighs the money. Because if you do a great job for the patient and a great job for the people you serve, the doctors and nurses, the money comes. The money always follows doing the right thing. I say that a lot. Sometimes the board disagree with me, but I know I'm right. What about pain and recovery? So, again, this is all baloney because pain is all based on how you interpret it, how you record it, demographics, men versus women. People can, report pain differently in different parts, but here's the reference if you want it. Now, this is a multi-centered randomized controlled trial, very tight entry criteria, as you can see here. But what do they look at? I'm going to tell you that this is also baloney, because if you're using a 30-degree camera versus 0-degree camera, we have pretty good data that your pain is higher. That's got nothing to do with the robot or VATS. So that's the problem with this study. They didn't control the degree of the camera. So we put a 0-degree camera on all our cases, and on the right chest, go over the 9th rib. On the left chest, I go over the 9th rib as well, but if I'm training you and you haven't done 100 robots, we have you go over the 8th on the left side for left upper lobes, or use a 30-degree camera because people are so uncomfortable being low in the left chest, going up on top of the left upper lobe. That's just the reality of VATS surgeons because their views are from the anterior chest. So if I'm training you and you're a big VATS surgeon, we're going to use a 30-degree down and go up higher. But 30 degrees hurt the nerves. I've never used the 30-degree. I use the word never. Is that true? Hardly ever. I think maybe 2 cases. I've done 19,400 operations and 2,700 robots now, and I maybe have used a 30-degree camera twice. So we think it hurts. So here's the data, but the reality is the data is a lot of baloney because it didn't control for the camera, and I'd rather dive into the important parts of the talk as opposed to just the data. Now here's a single-center randomized controlled trial. Also, this is robotic-assisted versus video. There's the reference if you want to look it up. Annals of Surgery in 2022. And the idea here was to look, patients were not blinded, obviously. Here's where the ports are. Now, here's again a difference if you look at the study. Dr. Park, one of the best robotic surgeons in the world, in my opinion, definitely top 5, doesn't even use my same technique. I use CO2 insufflation on everybody. I'm convinced it's better. I'm convinced it keeps the lung from drying out. It gives me more room, gives me bigger domain. Yes, it causes a little hypotension, but for those of you who've been in my OR, you know I don't use an A line, I don't use a central line, I don't use a Foley. The operation is done in an hour and a half. The anesthesiologist doesn't have time to know if we're hypotensive because we're done. That's the trick. Don't type and cross, don't type and screen, 1 peripheral or 2 peripheral IVs, and they go home in a day, they all go to the floor, and the blood pressure doesn't matter. And we've got, 2,700 operations that prove it's true. But Dr. Park does it open. So now you're comparing apples versus oranges because he has a little incision sometimes when he does this case. He has an advantage. He can put his finger in the chest and feel nodules. I can't do that. So I have to tag all my nodules. There's advantages to Dr. Park's way over my way. In any event, here's the data. If you look at this, statistically significant, no, but close enough. And now what about pain? So again, pain is reported, as I told you, in the visual analog score. Here's the reference. I can shoot 1,000 holes in this study. So I won't spend too much time, but to tell you, I think the key is getting your tube out. We are now removing our chest tubes before the people leave the OR. So I'm going to say that again because I've had visitors come, they can't believe it. And it has failed. I will tell the people, our esteemed speakers sitting here, I hate to have ideas and innovation that haven't worked, but I have a prospective randomized trial, 125 patients, where I have a digital air leak system at the end of a lobe or a segment. If the digital air leak is less than 50, I'm pulling the tube. And out of 125, I think I've pulled the tube on 70, and 7 patients have had to have an intervention in the recovery room. So I asked my fellow, is this good? She says, it's great. I said, I think it's terrible. We failed in 7. However, all those people just had a tube put back in their numbed camera site, and the other 63 had no chest tube, ever. So failure or not failure, I don't know. You're all worried about drainage. I'm going to tell you for the final time, drainage doesn't matter. If you do the lymph nodes first, if you pack, if you're sure they're not bleeding and there's no chyle, you don't need to measure it. So for 5 years, I've been pulling tubes out at 4 to 6 hours. For it's so stupid, I should have started taking tubes out sooner. Why did I do that for 5 years? Because I was stuck with my own dogma. So I submit to you, pain is related to the chest tube. We're going to find a way. What I'm doing now, if the air leak is between 75 and 50 on the digital system, I'm putting a pigtail catheter in through one of the port sites, so the patient wakes up with a pigtail instead of a chest tube because we have failed a little bit, and now I don't have to intervene on them. But still, they go home with a tube, or someone on my team has to remove a tube. That's labor, that's work, that's bad. Bad for the patient, bad for you. Patients should not ever sleep with a chest tube. If you do a lobe or a segment, it's inexcusable for them to spend the night with a tube in their chest. You should at least get it out at 6 hours. Inexcusable not to take it out unless they have an air leak. And I promise you they don't come back with effusions. Okay, that wasn't up there. It's a nice aside, but that's what we're doing now. Here's the data in this chest article, again, which shows the robots a little bit better. But again, it is flawed data. Now, here's a single-center, prospective, blinded, randomized controlled trial. You love that. Joel loves that. It sounds great, right? But again, there's all kinds of problems in this. The N is small. The statistics are weak. And it looked at minimally invasive, and it looked at a single surgeon. The outcome here was perioperative outcomes. I submit to you there's going to be no difference in survival because it all comes down to your ability to get negative margins and lymph nodes. And finally, I'm going to then skip to the lymph node, which is probably better with the robot, and then get the cost. So here's the biggest argument against the robot is cost. And I can tell you, as someone who has run a $9.2 billion organization for 6 years, I still don't know the right answer. And you're going to ask me how, and I'm going to tell you it's very confusing because we have 29 robots in my healthcare system, and we now have a program called AMP. We don't even pay for the robots. We only pay for the number of time the robot is used. So when I first got there, we paid $2.1 million to buy a robot. Now we pay nothing. If I want 4 more robots next week, I can get them at no cost. I just have to pay the amount that I'm using for each, like in the old days with copy machines. It's called per click. So there are these other programs available for high-volume systems. So now if you start amortizing the cost of the robot per usage, you can't. And at the end of the day, the cost is probably a little bit more for the robot. I'm going to show you the data. It's about $1,000. Here's one that it's $400. Here's one that's $4,000. Here's a thoracotomy. The cheapest thing in the world is for the patient to die immediately. So if you're worried about cost, the sooner they come in, the sooner they die, the cheaper it is. So again, it's not about cost. It's about value, value, value. And what is the value? The value is not just to the patient, but to the surgeon. Here's a length of stay, 6 days for thoracotomy. That's ridiculous because when we did thoracotomies, everybody went home in 3 days, and now they go home in 2. And now all the robotic cases go home in 1. So again, length of stay is all based on how you manage chest tubes. So if you look at this, which is a very good cost analysis, there's the reference Annals of Thoracic Surgery in 2014. It looked like it was about a couple $100 difference, and what they concluded here was if you could, I'll get right to it, if you could reduce your cost about $1,500, it was a wash. That's probably the best study about cost. And $1,500 in New York City is 15 minutes in the OR. So I like to teach. That takes me another 40 minutes to do a lobe teaching. Am I willing to give that up? No. But we have a 2-hour deadline. You got to be out of the operating room in 2 hours. So that means only about an hour and 30 minutes because you got medical students closing the incisions. That takes time. It takes 30 minutes to close incisions and opens with medical students and residents. So you can only be on the console for really about 60, 70 minutes. And if you're going to spend 15, 20 minutes teaching, to me, that's the way to do it. I can't figure out how to teach quickly. No matter what we do, the answer will be simulation and AI. It's coming. But still, people need to learn in the OR, and it's our job to teach. So you want to save money, get people out of the OR quicker, really get people home quicker. How many people in this audience are sending people home on post-operative day 1 after their lobes and segments? Good. That's great. How many? Hands up again. Well, this is fantastic. 1, 2, 3, 4. That is great. I submit to you that these are the leaders and these are the innovators. And do your patients get more likely to get readmitted? No. Do your patients come back with effusions because you took their chest tubes out sooner? No. I mean, they still do, but no more than they did before. You still have to intervene on 2 or 3% with maybe thoracentesis. They have less pain. Are they happier at home? Yes. So, oh, you said no? Why? You said you're not sure. Yeah, I guess who they're going home to. You know, if you don't like your spouse, then I guess you're happier in the hospital. So this looks at indirect cost and direct cost. We can talk all about that later. It's not a financial talk, but at the end of the day, it's cost effectiveness and value. So I have a few minutes late. I'm going to go back over value. Value is really your quality divided by the cost. You want to buy a cheap pair of pants that cost $100. If you're replacing them every 2 years, is that worth it? Maybe you spend $300 on a nice pair of pants. They last you 10 years. If you don't get fat, you don't lose too much weight, and it's a much better value. So you have to think about what it is you're spending your money on and why, and what's the actual quality and value, not cost. Surgeons are so fixed on cost. So I would get knocks on my door all the time because all the chairs of orthopedics and psychiatry and medicine reported to me, and I would tell them, don't worry about the money we bring in, because that's up to me to negotiate with our third-party payers, and we did a great job. NYU is the most expensive hospital in the United States, and I'm proud of that. We are the most, that is true, we are the most expensive hospital in the United States. Now, when I've told I have a boss, the dean, I'd like to be, that's not true. He goes, we're the best. I'm like, Bob, I'm not so sure we're the best. He goes, oh, we're by far the best. I'm like, you got Sloan Kettering down the street, they're pretty good. And Columbia and Cornell, they're pretty good. So he thinks we should charge the most. Whether we should or shouldn't, we do. The point is you better have the best quality. So I tell the surgeons, don't worry about what we get. Control the variables you can control, and that is your cost, which for a surgeon is 2 things, length of stay and time in the operating room. Adjuncts you use as a third, like if you want to use powder or Pro-Gel or other things, but really length of stay and time in the operating room. Control those 2 things and you'll be incredibly profitable. So I want to get to the conclusion because we have just a little bit left. You know, Bernie puts on all these slides, the robot is ideal. I'm not so sure it is ideal, but I will tell you it is more cost effective. And then finally, here's the big issue with the robot, and I'll end on this. It's not available to enough people. And in Europe and in other parts of Asia and other parts I've been, the patients get charged more for a robotic operation, which is ridiculous. Doesn't make any sense because the operation is no different. So we have to figure out a way to align third-party payers, hospitals, patients, and surgeons, and we haven't done it. And that's a whole nother lecture. I'll give it another time. So with that, I thank you for your attention, and I hope this was entertaining and a little bit informative. Thank you.